Hello, and welcome to this lecture on the anterior compartment of the leg and the dorsum of the foot. I'm James Sheffey, and I'll be walking you through this wonderful area of anatomy. I think you will find the contents of this lecture to be quite straightforward. However, they can be quite clinically significant, and therefore, I hope to be able to bring that to light so that you can understand the importance of being familiar with this region of anatomy. Well, let's jump right in. Starting now with the bones of the leg, we have the tibia and the fibula. These bones are connected by an interosseous membrane. The tibia articulates with the femoral condyles proximally, and the head of the fibula only articulates with the tibia. You'll find this to be important if you ever have a patient who has an isolated fibula fracture. You'll find that the fibula is non-weight bearing. Each of these bones has a distal projection. The tibia has the medial malleolus, and the fibula has the lateral malleolus. As you know from prior examinations, the bones are important to any area of anatomy, and I invite you to go into the lab and sit down with one of the skeletons or the bone boxes and make yourself familiar with all of the bony prominences that may serve as attachment point for the various muscles that you will learn in this section and others. Now, moving on to the compartments of the leg. You either have had or will have a lecture on the lateral compartment and deep compartment. These are two of the three compartments of the leg, the third being the anterior. This will be the topic of the lecture for today. Functionally, however, there are four compartments, and oftentimes you may hear of a four-compartment fasciotomy or something to that effect in clinical medicine, as the posterior is divided into superficial and deep compartments. Now, just a little bit of review. The boundaries are formed with the interosseous membrane, the anterior intermuscular septum, the posterior intermuscular septum, and the transverse intermuscular septum. The interosseous membrane goes between the tibia and fibula. The anterior intermuscular septum attaches to the fibula to separate anterior and lateral compartments. The posterior intermuscular septum attaches to the fibula to separate lateral and posterior compartments, and the transverse intermuscular septum separates superficial and deep posterior compartments. Now, as you can see, the common thread here is that all of these dividers attach to the fibula, and in fact, the treatment for compartment syndrome previously had been fibulectomy. However, this is not the current preferred treatment, but it does help you to understand the regional anatomy. Now, the great thing about learning these compartments separately is that oftentimes the muscles of a compartment will share an action, a blood supply, and a nerve supply. This is certainly true of the anterior compartment. All of the anterior compartment muscles are dorsiflexors. As you can see in this description, dorsiflexion is the process of bringing your foot toward your shin. Now, the opposite action is called plantar flexion, which will be covered in other lectures. Now, in addition to dorsiflexion, there may be a secondary action of inversion or eversion. The foot has a longitudinal axis that goes through the second toe. Muscles that attach medial to this axis tend to be inverters, and muscles that attach lateral tend to be everters. You will find that this holds true for the anterior compartment muscles. Now, diving more specifically into our compartment, the anterior compartment is bounded by the intraosseous membrane, the tibia, the fibula, and the anterior muscular septum. The contents of the anterior compartment include these 4 muscles, and I will go through these from medial to lateral. The tibialis anterior, the extensor hallucis longus, the extensor digitorum longus, and the fibularis tertius muscle. Again, all of these muscles share a common action of dorsiflexion. All right, let's dive a little bit deeper. The tibialis anterior has a proximal attachment of the tibia and interosseous membrane. Its distal attachment is the medial cuneiform and base of metatarsal 1. Its action is dorsiflexion of the foot at the ankle joint and inversion of the foot. Its innervation is the deep fibular nerve, and its blood supply is the anterior tibial artery. Next, we have extensor hallucis longus. Its proximal attachment is the fibula and the interosseous membrane. Its distal attachment is the distal phalanx of the great toe. Its action is to extend the great toe and dorsiflexion of the foot. Its innervation is the deep fibular nerve, and its blood supply is the anterior tibial artery. Next, we have extensor digitorum longus. Its proximal attachment is the fibula and lateral tibial condyle. Its distal attachment is via dorsal digital expansions into digits 2 through 5. Its action is extension of lateral digits 2 through 5 and dorsiflexion of the foot. Its innervation is the deep fibular nerve, and its blood supply is the anterior tibial artery. The fibularis, also known as peroneus tertius, is the next muscle. Its proximal attachment is the distal part of the fibula. Its distal attachment is the base of metatarsal 5. Its action is dorsiflexion and eversion of the foot. Its innervation is the deep fibular nerve, and its blood supply is the anterior tibial artery. All right, so this is basically what we just went through on the previous slide. However, I've put it into words for you. You'll also find a copy of this in the handout so that you can familiarize yourself with this. Next, let's move on to the neurovascular structures of the anterior compartment. We have the deep fibular nerve. For your purposes, you'll want to know that this contains spinal segments L4, L5, S1, and S2. We won't get any more specific than that. It is one of the 2 terminal branches of the common fibular nerve. You can see the branching happening here. It arises between the fibularis longus muscle and the neck of the fibula. It pierces extensor digitorum longus to distend on the anterior surface of the interosseous membrane in the anterior compartment. It accompanies the anterior tibial artery between extensor digitorum longus and tibialis anterior muscle. It travels between tibialis anterior and extensor hallucis longus muscle to emerge on the dorsum of the foot to become cutaneous innervation to the web space between the first and second toes. Moving on to the blood supply, we have the anterior tibial artery. It's a branch arising from the popliteal artery. It passes anterior through a gap over the interosseous membrane to reach the anterior compartment. It descends on the interosseous membrane between tibialis anterior and extensor digitorum longus muscle. It accompanies the deep fibular nerve through the compartment and beneath the superior extensor retinaculum to reach the dorsum of the foot. As it crosses the ankle, it will transition in name to the dorsalis pedis, which will become more important as we reach the dorsum of the foot. All right, switching gears and moving on to the dorsum of the foot. Again, I'd like to remind you of the bony structures. The tarsals, the proximal row is the calcaneus, the talus, and the navicular. The distal roll is the medial, intermediate, and lateral cuneiform and the cuboid. Metatarsals are numbered 1 through 5. Now, in regards to phalanges, toes 2 through 5 have proximal, middle, and distal phalanges. The great toe has only proximal and distal phalanges. This next image is to stress the point to you that there are ligaments associated with all of these bones, and certainly these can be of clinical significance. However, I'm not going to dive into the depth of going through each and every ligament. We will, however, look at the tendons on the dorsum of the foot. Many of these are continuations of the muscles that we just discussed in our anterior compartment of the leg. The tibialis anterior tendon, the extensor hallucis longus tendon, which you can see traversing its way toward the great toe, the extensor digitorum longus, which you can see spanning out and going to the digits, the fibularis tertius, which you can see going to its distal attachment. Now, the interesting thing about the ankle is that there is an extensor retinaculum. There is both the superior and the inferior extensor retinaculum. Imagine this as being an area in which the tendons are bound to prevent bowstringing during dorsiflexion. The superior extensor retinaculum extends from the fibula to the tibia over the tendons belonging to the muscles in the anterior compartment. The inferior extensor retinaculum extends from the lateral cutaneous to the medial malleolus. It bifurcates into this rather prominent Y shape, and it attaches to the medial malleolus and the medial cuneiform over the anterior compartment tendons. It forms a strong loop for tendons leaving the lateral compartment of the leg. Alright, since we've already discussed the anterior leg muscles, and there were longus muscles there, whenever we have a longus, we know we must have a brevis, and they're found in the dorsum of the foot. These two muscles are the extensor digitorum brevis and the extensor hallucis brevis. They function to extend the toes. Alright, now taking a dive into the neurovascular structures in the dorsum of the foot, we'll start with the deep fibular nerve, also called the peroneal, deep peroneal nerve. It lies lateral to the anterior tibial artery at the ankle. It innervates both of the muscles of the dorsal foot, and it provides cutaneous supply to the skin between the first and second toes. Now, the medial and lateral dorsal cutaneous branches of the superficial fibular nerve provide sensation to the remainder of the dorsum of the foot, as you can see represented in this image. And there's more details on this relationship in the handout. Again, pay attention to the cutaneous sensation here, right in the web space between the big toe and the second toe. And the superficial fibular nerve providing that remainder of the dorsum of the foot. Alright, moving on to the vascular supply. This is the anterior tibial artery, which as it crosses the ankle becomes the dorsalis pedis artery. This is important in your physical exam as it is a place where a pulse is taken. It is just lateral to the extensor hallucis tendon. It is crossed by the extensor digitorum brevis tendon before it disappears between the two heads of the first dorsal interosseous muscle to form the deep plantar artery. It has branches including the deep plantar artery, which contributes to the plantar arterial arch, the arcuate artery, the medial and lateral tarsal arteries. All right, so now that you have an understanding of the anatomy of this region, we're going to dive into some of the clinical aspects. One of the things that you're likely to see is intraosseous infusion. Now, intraosseous infusion is a method of delivering hydration, blood, and medication directly into the medullary cavity of a bone when peripheral venous access is difficult or impossible. This is particularly important in the pediatric patient population. In fact, I believe that there are many practice guidelines that would state 2 failed IV sticks in a patient less than age 6 would be justification for placement of intraosseous infusion. A specialized insertion kit is available. It does involve a drill. It's readily available to first responders and acute care providers such as emergency room physicians. The most common site of insertion is in the proximal tibia. Now, as you're aware, in a patient under the age of 6, their growth plates will not have been fused yet, as their long bones are still growing. And it is important to avoid the growth plate when inserting intraosseous infusion catheters. Next, we'll discuss compartment syndrome. This is a great way to refresh yourself on the various compartments: the anterior compartment, the lateral compartment, the posterior compartment with its deep and superficial subdivisions. Also a great way to put things together for your cross-sectional anatomy. As you know, in subsequent clinical practice, there will be MRIs and CT scans and the like that portray anatomy as cross-sections. So compartment syndrome is a syndrome involving increased pressure in any of the 3, as I've noted before, clinically 4 compartments of the leg, leading to a vascular or neurologic compromise. The anterior compartment is the most common location and makes it particularly germane to this lecture. In its acute form, this is considered a surgical emergency, as failure to treat will result in severe debility. The symptoms are the 5 Ps: pain, pallor, paresthesia, pulselessness, and paralysis. Now let's take a look at the surgical approach to this. Generally, a 4-compartment fasciotomy is performed through an anterior lateral incision and a posterior medial incision. As you can see, access to these compartments is obtained through a common incision. Oftentimes, upon entering into these fascial compartments, the muscles will bulge through the opening in the fascia. This does necessitate leaving the compartments and their overlying incisions open to allow for complete decompression. Next, let's talk about deepfibular nerve entrapment. This is also known as ski boot syndrome. Classically, this is due to tight-fitting shoes causing compression of the nerve. This leads to pain on the dorsum of the foot that radiates to the web space between the first and second toes. As you can see, these are the potential points of entrapment, depending on the particular design of the boot. Next, let's talk about anterior ankle impingement. This is also known as footballer's ankle. This condition involves pain on the front side of the ankle. This area noted with the star and the arrows. Inflammation and swelling occur due to repetitive stresses at end-range positions of the ankle, such as when one jumps, squats, or descends stairs. These may eventually lead to development of bone spurs, a bony overgrowth in the ankle joint space. Think of this as the chronic or end presentation of multiple severe ankle sprains. In your physical exam class, you will no doubt learn how to palpate a dorsalis pedis pulse. There are significant anatomic landmarks to make this process easier. Extension of the great toe will result in accentuation of the extensor hallucis longus tendon. Immediately lateral to the tendon, the pulse will be palpable on the dorsal surface of the foot. Note, there are some congenitally absent dorsalis pedis pulses. However, you oftentimes will find this to be bilateral, and a unilateral finding would be concerning. Next, we'll talk a little bit about shin splints. Shin splints are a pretty common condition, and you may have experienced it yourself, or perhaps someone you know has experienced it. But the term shin splints are not particularly descriptive. It's often an all-inclusive term that's used to describe pain in the anterior compartment of the leg. Most commonly, shin splints are caused by physical activity in which the foot is lowered to the ground following heel strike, such as occurs when running, and especially when running downhill. The pain is due to inflammation of the periosteum of the tibia. In more severe cases, shin splints can result in stress fractures. As you can see, this is a patient information handout represented in your slide using Netter images, and it explains the process of shin splints. I include this slide to focus in on the most common area of symptoms. As you can see, the most common area of symptoms for shin splints is in the distal aspect of the leg. All right, well, that wraps everything up. Hopefully, this helps you to gain a greater understanding of the anatomy of this region. In addition to that, it helps you to understand the clinical significance and will aid in your ultimate dissection and progress through the course.